6:30 ಆಯ್ತು ಅದರ
ಮಾಡ್ಬಿಡಿ.
Good evening everyone.
Azam ಬಂದಿಲ್ಲ Azam.
I on behalf of ISA Karnataka invite all of you for 18th monthly academic meet. Today's topic is pediatric regional anesthesia tips and tricks presented by our renowned anesthesiologist Dr. Sanjay Prabhu, a consultant anesthesiologist at Apollo Hospital, Chennai. Welcome you, sir. I would like to invite our President ISA Karnataka, Dr. Manjunath Ejji, past President ISA Karnataka, Dr. Vijayanandas, our academic advisors, Dr. Balbhaskar S, Dr. Gurudat CL, Dr. SB Gangadhar, Dr. Danish Azam, and Dr. Ravi R. And also I would like to invite all the delegates, postgraduates for this interactive webinar. Today's webinar will be moderated by Dr. Balbhaskar S and Dr. Gurudat CL. Now I request our President to give opening remarks.
Thank you, Dr. Shivkumar. Good evening, dear all. So, greetings from Indian Society of Anesthesiologists, Karnataka State Chapter. So, today we are having our monthly online academic program. That is number 17th, I think, Dr. Shivkumar. 18th. Today we have with us Dr. Sanjay Prabhu, Apollo Hospital, Chennai. We will go to speak on pediatric regional anesthesia tips and tricks. And today's moderator are Dr. Balbhaskar and Dr. Gurudat CL. And as per the ISA office bearers meeting which was held in PGXL 2022 in Kolar, we have included Dr. SB Gangadhar, Dr. Danish Azam, and Dr. Ravi as subsequent moderators for this academic program for the next meeting onwards. And I welcome Dr. Gangadhar, Dr. Danish Azam, and Dr. Ravi R. And each and everyone knows about all the three. And especially Dr. Danish Azam is well known as a DNB teacher in Bangalore and other cities. And Dr. SB Gangadhar is a professor and head of the Department of Anesthesiology, Siddhartha Institute of Medical Science, Tumkur. And Dr. Ravi is a professor and head of the Department of Anesthesiology and Sridevi Medical College, Tumkur. So they are joining from this month onwards as a moderators for subsequent online teaching webinars. On this note, I would like to invite our Secretary, Dr. Shivkumar, to proceed with the proceedings. So it's over to Dr. Shivkumar.
Thank you, sir. I would like the moderator to introduce our speaker, Dr. Sanjay Prabhu. I request Dr. Gurudat to introduce our speaker.
Okay, good evening, everybody. It's a pleasure to introduce Dr. Sanjay Prabhu to all the audience and also the viewers. You know, Dr. Sanjay Prabhu is a pediatric anesthesiologist from Apollo Children's Hospital, Chennai, India. He's also a pain specialist in Apollo Hospital, Chennai again. So he did his BBS from Madras University, MD anesthesia from Pune University. And he has also done his CCST from Mercy Deanery, Liverpool, UK. Pain fellowship from Faculty of Pain Medicine, Australia. And also he is a secretary of Tamil Nadu State Branch of Indian Association of Indian Society of Pain. So, also he has got 6 publications in index journals and authored a book chapter on pediatric regional anesthesia. So since he has also authored a pediatric regional anesthesia, he is a pain specialist. He's also working in pediatric hospital. He is a pediatric anesthesiologist in a hospital in Apollo Hospital. I think he is the best person to talk on pediatric regional anesthesia tips and tricks. So over to Dr. Sanjay Prabhu to take over as the speaker.
Thank you very much, Dr. Gurudat, sir. It's a very kind of you for a wonderful introduction. And I've known sir for quite some time, and he's a wonderful speaker. So, yeah, I've got a lot of senior faculty watching me, so I hope I do a decent job. So thanks for inviting me for this academic program. And I was quite impressed with the monthly program which ISA Karnataka is doing. So hats off to all the organizers of this one. So yeah, so let me, can I share my screen?
You have access, sir. You can share.
Okay, yeah. So can you all see my screen, sir?
Yes, sir.
Okay, great. So yeah, if the time allotted is probably 40 minutes to an hour, I'll try and keep it as short as possible. But if I'm exceeding my time, Dr. Shiva, please let me know. I can stop wherever. Okay. So yeah, I think that's done. That's my hospital. So it's a relatively small hospital compared to the bigger hospital, but it's a tertiary referral center for pediatrics. It's an 80-bedded hospital, so we do all surgeries from cardiac to neuro to vascular. So I don't do cardiac; I do everything except for pediatric cardiac anesthesia. Now, so I thought I'd just start off with a question just to stimulate a few minds here. So which of the following is correct? Only one answer is correct. So infants. So this is more for the postgraduates who are sort of exam going. Infants have a higher threshold for pain. Local anesthetics take longer to work in small children. The risk of toxicity is higher, or the free fraction of the drug is lower in small children. So yeah, you can tick the answers in your own mind, but we will get to know the answers as I talk through the slide. Am I audible, Dr. Shiva?
Yes, sir. Yes, sir.
Okay, fine. Yeah, just to make sure I'm audible.
Delegates can answer in a chat box.
Oh, okay. Yeah. So, so why is this topic important? I'm glad this topic was given to me, and I'm glad this is one of the topics being discussed. So, I'm quite passionate about treatment of pain in small children, basically because I think children have a lower threshold for pain, particularly children less than 2 years of age. And the highest pain, the age group most vulnerable pain is usually the neonates. So though earlier it was told that they have an immature nervous system who they cannot perceive pain, but now this has completely changed. A child can perceive pain from 20 weeks in utero. And unfortunately, some of the mechanisms which transmit pain make the pain feel more exaggerated. So a small child will feel more pain given the same noxious stimuli. Apart from that, any child coming for anesthesia, I make sure there is some kind of a block given, providing we can give a block. So that tends to decrease the amount of opioids and also tends to decrease the MAC required for maintaining anesthesia. And you have a comfortable looking child in the recovery. And it's an important component of multimodal analgesia. And lastly, there has been a lot of papers talking about the neurotoxic effects of giving anesthetic agents. So by giving a regional block, we can minimize the effect of these medicines on the brain. So yeah, that's some reasons why we should try and promote regionals as much as we can. Now, so briefly going through some points how it is different in pediatric age groups. So we'll go through the anatomical, physiological, and the pharmacological differences. So to start off with, a nerve, given that children are smaller in size, they also have smaller nerves, a smaller diameter of the nerve. The nodes of Ranvier, which are these points here, are more closely placed. That's number two. And if you see, myelination is complete by 8 to 12 years of age. So in a newborn child, myelination is very minimal, and it slowly increases its density around the nerve. And the second point is, because the children are small, the target or the depth from the skin is quite limited. So what does this imply clinically? So you need to have, you can use a linear probe in ultrasound for most of the blocks in children. And one more point is, if you look at this different layers of the nerve, you have the epineurium at the top, then you have the perineurium, and then you have the endoneurium. The amount of connective tissue in the endoneurium is quite less, which means the nerve, the local sites tend to percolate into the axons very quickly. So all these basically translate into a quicker onset of blockade. That is one. And second is the dilution of anesthetic required for blocking a nerve completely is less in a small child because of lack of myelin, because of a shorter distance from the skin, smaller diameter of the nerve, decreased distance between the nodes of Ranvier, and less connective tissue. So you need a less concentration of anesthetic to block even the motor components. That's why a 0.1% of bupivacaine or ropivacaine will be enough for most children to do a block. Other differences in the neuraxial blockade would be the CSF volume is much higher in a neonate, higher in a small child compared to an older child or adult. Second is the spinal cord in the dura mater tends to terminate 1 or 2 levels lower compared to an older or an adult patient. And finally, the thoracic spinous processes are sort of perpendicular to the skin. They're not acutely angulated like the adult patients. So it is easier to do a thoracic epidural in a small child. The implications of above points basically means that when you give a spinal for a small child, because of the higher CSF volume and the increased circulation of CSF, the duration of action of spinal is quite small. So it can be used for procedures lasting for 20-30 minutes, but beyond that, they start moving. And the needle entry point has to be based on this point. So a spinal is normally done below L4, L5, and there's a high risk of dural puncture in the caudal space as well if you insert the needle too deep in. Other differences physiologically would be this particular compound called alpha-1 acid glycoprotein. It tends to bind the local anesthetics in the blood. So children have a less concentration of this one, particularly the infants. So which basically translates to an increased free fraction of the drug in the blood. Second is they have immature hepatic systems to metabolize medicines. So this tends to increase the risk of local anesthetic toxicity in a small child, particularly when you exceed the dose. Other points, because of a higher cardiac output and a higher heart rate, when you deposit the anesthetic into around a plexus or in a tissue, they get absorbed quickly. So basically, this means the duration of anesthetic could be shorter, and the increased heart rate tends to increase the risk of cardiac toxicity in small children. One important difference between adult and pediatric patients is all the blocks has to be done under sedation because they're not going to cooperate as an age group. But there are certain exceptions where you try as much as you can to use only a visual block. This classically, the most classical example would be a preterm baby because they have a high risk of apnea in the postoperative period. We try and give spinals with the child awake. Okay. Other categories would be children who can cooperate, typically the adolescent age group, or in situations where giving a GA can potentially be life-threatening for a child. This is typically a condition like anti-medicinal mass, where any form of anesthesia can cause complete airway obstruction. So these situations you try and promote local anesthetic blockade. Now, all of us are quite familiar with ultrasound, and it seems to be sort of a gadget which is quite familiar with most anesthetists. The same applies to giving a regional anesthesia. So I think it is probably the way to go in the future. And in pediatrics, particularly, it's very important because, as I said earlier, the nerves are quite superficial, and because of the small size of the child, the structures are quite closely placed. So you could have a nerve, artery, a vein, or a pleura very close by. So to delineate the structures clearly, you need an ultrasound which can give you a live or a real-time imaging of what you're doing. So this basically means that you can give a less volume to block a nerve. It can also pick up some anatomical variations, which cannot be seen when you do a penis-guided block. Now, in terms of probe selection, as I said earlier, the linear probe will be enough for most patients. But however, when you have a very small child, a 6-month-old child for a brachial plexus blockade in the neck, this may not fit. The footprint is quite big, so you might have to use a smaller probe. And the needle trajectory can be quite short because of the depth from the skin to the target location. Okay, I find this quite scary. So I've had a couple of instances where the nurse asked neurosurgeon for a craniotomy, how much to infiltrate. A 1-year-old child weighing 10 kilograms. And the neurosurgeon report says that we can give 2% lignocaine with adrenal 3 mL and 0.5% lignocaine 4 mL. So I'm sure most of the anesthetists will agree that this is a gross mismanagement because the dose, you never combine 2 local anesthetic drugs. And even if you combine them, you have to half the dosage. Okay, here he's giving the maximum dose of lignocaine and the maximum dose of lignocaine for this child, which is certainly not recommended. So some important safety precautions when you do regionals is because you have a wide range of children across different age groups having different weights, make sure you drop only the dose and the volume required. So calculate the dosage and try to give less than the maximum dosage. That's always a dictum in regional anesthesia. Try and give less than the maximum dosage. That's number one. And never sort of do anesthetic block with the needle and the syringe attached to each other. So always have some tubing in between so that movements of the needle or movements of the syringe don't translate into movements of the needle. So this is something because in small children, you can easily sort of displace the needle while manipulating the syringe, and this can potentially cause complications. And always have one person having the to watch the monitor, the ECG, and I'm sure one of you will always be hearing the pulse oximetry, the beep sound. And if possible, try as much as you can to keep the patients breathing spontaneously, because sometimes when you do a caudal injection in a small child, since they're already sedated, you don't get the warning signs of a local anesthetic toxicity. So if you inject the caudal anesthetic into the subarachnoid space, the first thing the patient will do is they will stop breathing. Okay, so have the patients breathing spontaneously. Okay, this is one important question which I ask in all my questions, all my presentations about regional anesthesia. So when you practice regional anesthesia regularly in a place, what extra drug would you keep ready in your OR? So I would love to see some responses from the postgraduates. Okay, I'm not sure how many of you have this in the OR, but it's something which is strongly recommended. The reason being, suppose you have an intravascular injection of the anesthetic. The only way you can get the patient back is to give this drug. Otherwise, they go in for a refractory ventricular tachycardia, ventricular fibrillation, and you're just going to lose the patient. Okay, so when you give infusions for the in the postoperative period, it's important to note that in small children, particularly neonates, because of the reasons we talked about earlier, there is a slow increase in the concentration of the anesthetic in the plasma in neonates because of these 2 points. So generally, we recommend that continuous infusions in children less than 3 months of age, you try and keep them less than 48 hours. And even during that time period, you try and monitor them with a monitor, preferably in the ICU or HTU. Now, so the reason why we need to keep looking at the ECG when you do regional is to alert you to the warning signs of toxicity. So the top one is a normal looking ECG. Apparently, in small children, the first sign which can alert you to a risk of intravascular injection is an increase in the T wave amplitude, as shown in this second graph here. So you could have an increase in T wave amplitude, or they could have HTT changes, or they could have tachyarrhythmias or bradyarrhythmias. So always keep looking at the monitor when you do a block, or have someone watch the monitor. Now, this is standard teaching in all textbooks, where it says that we should be adding adrenaline to alert us to an intravascular injection. But the studies have shown that in children, there are so many confounding variables. So adding adrenaline may not be sensitive or specific to pick up an intravascular injection. So they don't recommend it as part of the technique. And if you're wanting to add adrenaline to increase duration of blockade, it's not recommended, because we have better adjuvants which are safer. Now, this is an article which is worth reading for someone who does pediatric anesthesia quite regularly. It's called Error Traps in Pediatric Anesthesia. Some nice points in that article, published in August last year. So one of the slides from that one was always have a pre-procedural checklist to make sure that you're doing the correct patient, the correct site, the correct side, and you have all the equipment necessary in case the child goes in for a complication. Even if you do a block with the child sedated, you still want to minimize the pain of injection. So try and have a smaller needle, minimize needle trajectory, and use the injection, inject it slowly, incrementally in fractionated doses. One is to decrease pain and to alert you for any complications. And you can alkalize the injection with adding sodium bicarbonate. You can add 1 ml for every 10 ml of local anesthetic. I still see a lot of hospitals practice anesthetic with bupivacaine, and I've personally stopped using bupivacaine because I think when you have a safer alternative, why go for an inferior drug? So if you have access to these two medications, they are probably the best as of now. because they are less cardiotoxic. That is the first important indication. They're also less neurotoxic. And with ropivacaine, there seems to be a less amount of motor blockade. So if you want someone to ambulate after a caudal, then maybe the ropivacaine is better. In terms of efficacy and duration, they are the same as ropivacaine. So I would probably recommend these two as the main drugs for any block. So we'll go through some common blocks which we practice. I'll try and cover only blocks which are relevant to pediatrics. So because otherwise it will be too long to cover everything. Now, there has been a lot of emphasis in recent times to move from central block to peripheral blocks. So basically, what two major studies, one in France and one in US, have shown that the risk of complications is higher whenever you use a central neuraxial blockade, and the complication rate is 6 times higher. And when you do a peripheral block, again, the proximal blocks have a higher complication rate compared to the distal blocks. So so the trend is to move towards peripheral nerve blocks and away from central neuraxial blocks. Now, again, I think there is a lot of variations in how people practice what antiseptic they would use. So, so when you're doing a single block, a single shot block, you can wear a glove and use the best agent. But when you're using a continuous block, like insertion of an epidural catheter or a continuous plexus catheter, you have to be more aggressive with the antisepsis and the way you do it. So maybe wear a gown, a mask, and so on. Now, among this, which one is the best? So the postgraduates, again, you can answer which one is the best, whether it's povidone-iodine, alcohol, chlorhexidine with alcohol, or Savilon. So the answer is the third one, chlorhexidine with alcohol. It's the best one because it's got a combination of two agents, one which acts quickly and one which is has a lot of residual effects, so it acts for a long time. So that's the preparation which we use in our hospital. So it's called AHT. It's a combination of 2% chlorhexidine and 80% ethanol. Now, one point about the chlorhexidine, when you use it as a skin prep, it can cause chemical arachnoiditis. So when you use it for a central neuraxial blockade, make sure that the solution is dry. When you dry, you get the maximal effect. And second is you minimize any injection of that particular agent into the skin or into the neuraxis. That's one. And second is there is this entity called chlorhexidine allergy. The unique thing about this allergy is it doesn't manifest immediately. So if someone tends to hypotense, become tachycardic, sort of 45 minutes, 1 hour into a procedure, this could be one of the potential causes. So when you use chlorhexidine for skin prep, just remember this as one of the possible reasons why you could have an unstable patient. Very important. If you have a patient who can understand what you're going to do, then it's always good to explain why you're doing a block, what are the benefits, and some children don't like having a numb hand or a inability to move their legs after when they wake up. So it's important to explain to them that they will have a numb hand for 12 to 14 hours after a break block. Or in small children, 3 or 4 years of age, you have to warn the parent that they cannot ambulate or they might be unsteady on the feet because of a caudal blockade. So that's one important reason why we take consent for a block. And second is obviously the legal issues related to a block and its complications. So these are 3 things which we commonly do: a caudal, spinal, and epidural. And I'm sure all of you know that children up to 8 to 10 years of age, because of a high parasympathetic dominance, they don't have any hemodynamic instability with the spinal blocks. So caudal is the most common block which we perform in the pediatric age group. So the space is basically the fourth sacral interspace is where the sacral hiatus is present. So basically the lamina don't fuse in the midline and you have a dimple there, and that's where you insert the needle. Most anesthetists tend to do it blind, but there are certain indications where ultrasound is important. The caudal can be used for a single shot, and we can also thread a catheter from the caudal space up to the thoracic dermatomes because the epidural fat is very fluidic in children. So that's why you can easily thread a catheter. And even giving a drug into the caudal space, you can the fluid can spread up to the thoracic dermatomes. So by doing a caudal, you can also do a sort of upper abdominal laparotomy quite comfortably. There is something called the transsacral approach, where you go one or two levels higher. In some people, you cannot feel this dimple, so you might have to go at the S2, S3 interface. So that's the caudal space. So when you do a block, that's the dural sac ending at S3, S4 and A. So you're quite close to the dural sac. So you could potentially cause a dural puncture if you introduce the needle too much into the patient. So the initial angle is usually a 45 degrees angle. And once you enter the sacrococcygeal membrane, you depress the needle and push it further in so that you're in the space. And the ultrasound, this is what you see, a Mickey Mouse pattern. So that's the two sacral cornua at S4 level. That's sacral bone. That hyperechoic line is the sacrococcygeal membrane. And this hypoechoic space in between them is the caudal space. So when you inject the drug, you will see this particular space expanding. So the next one is a video about me doing a caudal. So it's called the pop and the drop technique. You pop the sacrococcygeal membrane, you drop it. You disconnect the needle to see if there's any CSF. And I do that every 2 or 3 minutes to make sure that the needle doesn't get displaced whenever you inject it. And it also minimizes the pressure on the spinal cord. So try not to inject too quickly. Incremental injections, you can either aspirate or disconnect. And when the fluid doesn't come back when you disconnect. So every time I disconnect, the fluid should not come back. If it is coming back, probably you're not in the epidural space. That's one of the clue that you're inside the caudal space. Now, in some children, you can have some cutaneous markers like this one. So this is a child which we did yesterday for a tethered cord syndrome. Okay, so this was all the patient presented with. Okay, so when you have such a thing over the sacral region, then you look for any neurological abnormalities, or you have to be quite cautious about doing a caudal, because one is there could be anatomical variation, and second is it might be difficult to do a caudal. Third is you might cause some complications if you do a caudal. So what anatomical problems can occur? So when you have multiple dimples, or if the size of the skin lesion is more than 5 millimeter diameter, if it's more than 2.5 centimeters in the anus, or if it's associated with an underlying lump, all these can make your caudals quite difficult or better to avoid in this situation. So that's again another flow chart from this article which I mentioned. So whenever you have a skin lesion, you do the neurological examination. If it's normal, then they look for other features like the dimple size and the distance from the anus. If none of them are there, then you can go ahead with the block. Otherwise, you do an ultrasound guided block or do an MRI to look at the abnormalities inside. Okay, briefly about spinals in small children. The only age group where we do a spinal is in preterm babies, because the risk of apnea in the postoperative period is quite high, particularly in children born less than 37 weeks and up to 50 weeks post-conceptual age. So if anyone was born before 37 weeks, for at least for the next 12 to 14 weeks, they are at an increased risk of apnea. So these situations, we try and do the spinal, try and do the anesthesia only under spinal. This is typically for patients coming for surgeries like circumcision or herniatomy, because these two are the very common surgeries in this age group. Yeah, that's the dose, and you need to know that it's a very short duration. So if it's going to be a long duration, you might have to do a combined spinal with a caudal. So that's a child who we have given a spinal for a neonatal circumcision, and we're just blowing oxygen from a mask, and child is quite comfortable while the surgeon is operating. So you can see the surgeon operate. Now, one common thing is dural puncture, more common in children. It is quite common. One is because the depth in the skin is quite limited. And second is the ligamentum flavum is quite thin, so you can one is you may not appreciate a definite loss of resistance, and second is it's thin, so you can easily cause a dural puncture. So whenever you use catheter techniques, you need to maintain rigorous aseptic techniques. If possible, tunnel the catheter to minimize the risk of infection and displacement. And try and use local anesthetic infusions with low concentrations. This basically applies to surgeries where you think there's an increased risk of compartment syndrome. So some surgeons, they don't want any local anesthetics, but if some surgeons agree, then try and give anesthetic infusion which is low enough so that you can pick up warning signs of a compartment syndrome. Okay, these are all the various truncal blocks. I'm not going to go into the details for most of them. So basically, most truncal blocks are fascial plane blocks. Basically, it represents the anesthetic between two muscular layers. So you need a large volume. In most of the time, you cannot see the nerve, but you might see some arteries. And so obviously, because of these reasons, you need to have an ultrasound whenever you do a truncal blockage for a good success rate. Penile block, again, the most common surgery which we do in children is circumcision. So that's the penile block. That's the anatomy showing the dorsal nerve of the penis, which is usually present at the 9 o'clock and 11 o'clock position, lateral to the dorsal artery. Now, next thing which I commonly do for children coming for hypospadia surgery, or any children who we cannot do a caudal for whatever reason, or a failed caudal, we do a pudendal nerve block. So briefly, anatomy of the pudendal nerve, it's a nerve coming from the S2, S3, S4 from the sacral plexus, and it tends to supply the external genitalia, the scrotum, and the perineal region. So it's good for any surgeries involving the penis, part of the scrotum, and the perineal region. So basically, you place ultrasound machine or the probe in the gluteal region with the patient in the lithotomy position. So what you see is you will see two hypoechoic structures. One will be the ischial tuberosity, another one will be the anus, and the fossa between the two is called the ischio-rectal fossa because it is between the ischial tuberosity and the rectum. So it's the ischio-rectal or the ischio-anal fossa, and usually the pudendal nerve runs that particular fossa. So that's the position which we do. So child is held in a sort of a lithotomy position. Probe is placed in this particular orientation, and it's a outer plane technique where we go here on both the sides. Okay, so here you will see the fluid spreading quite comfortably in the ischio-rectal fossa. You may see a pudendal artery, but it's a tortuous artery there, so you don't necessarily see it all the time. But it's got a fairly good success rate, and I've had a success rate of almost 90%. I must have done more than I've been doing it for the past 3 years now. Again, a very common operation in children. So I'm not sure how many of you practice infiltration of the anesthetic into the tonsillar fossa, or how many of your surgeons do it, but a couple of our surgeons do it. I'll just show you a video of how they do it. Okay, so that's the tonsil there. Okay, the tonsil is between two pillars, the palatoglossal fold and the palatopharyngeal fold. So they infiltrate in the tonsillar fossa, and as they inject, you can see that the tonsil will slowly sort of bulge medially. And by injecting this, I think one is they have good pain relief during and after the operation. Second is it creates a plane for the tonsillar resection. And third is it tends to minimize bleeding because they inject a combination of both adrenaline and lignocaine. If you see, as he injects, the tonsil tends to slowly move medially. So all of you should try and probably encourage your surgeons to do this. You have a much more comfortable child when you have this anesthetic at the start of the surgery. Now, is there a role of adjuncts in pediatric anesthesia? Definitely yes, because most of the blocks which we do tend to last for a short duration, and it may not cover the entire duration of the pain that the child is likely to perceive. So given a choice, if there is no contraindication, always add an adjuvant. So there are various adjuvants which we tend to use. For epidurals, we tend to use either fentanyl or clonidine along with the anesthetic agent. For caudals, we tend to use a single shot buprenorphine. We use, particularly in surgeries like hypospadias, we use 2 mics per kilogram because they are admitted overnight. And yeah, for the next 24 hours, they're quite comfortable with this particular drug. And for infusions, you can use either fentanyl or clonidine. Clonidine compared to opioids has some benefits. One is because there are minimal opioid-related side effects. And it's very unlikely you will overdose someone with clonidine because the toxic dose is quite high. And there is also some papers recommending that fentanyl should not be used in small children because of the risk of apnea, but the same risk doesn't apply to clonidine. And other drug which we use in caudals as a bolus is dexmedetomidine in the dose of 1 to 2 mics per kilogram. So a 2-year-old child is coming for a thoracotomy. What can you use for pain relief? I'm sure all of us know about epidural, but what are the other options we have? So I'm sure all of you heard about paravertebral block. It's quite commonly practiced in some centers which do thoracic anesthesia regularly. So it's similar to you inject it at the paravertebral space, and it's well seen in small children, again, because the distance from the skin is quite shallow. So that's how you see that's what you see in the ultrasound image. So the best way to say that you are in the paravertebral space is when you inject the drug. When you inject the drug in this particular place here, so that's the transverse process, okay? That's the costal transverse ligament, and that's the pleura. So whenever you inject the drug, if you can displace the pleura downwards, that is a fairly good indication that you're in the correct place. Now, one of the blockade, again, which is very commonly practiced nowadays, is the erector spinae block, which is given by contacting the transverse process. And here again, it tends to block the spinal nerve as it comes out from the intervertebral foramen. And unlike the fascial plane blocks like the tab block and the QL block, since this is close to the neuraxis, it tends to cause both a complete blockade, and it provides both visceral and somatic analgesia, unlike TAP, which causes only somatic analgesia. So erector spinae muscle plane block is quite simple because one is you have a definite endpoint, you tend to contact the transverse process and then inject the drug. That's why you inject the drug. Okay, so that's the transverse process. You inject the drug and you will see the erector spinae muscles being lifted, and it will spread longitudinally. So that's a fairly good sign that you're on the correct place. Okay, so a 3-year-old child is having a sternotomy, resuturing. So what kind of a block can you use? I'm sure all of you could say you can use just an infiltration around the wound, or you could use a PEX block or a SAP block. Okay, there's something called the Pectointercostal facial pain block. Okay, so I'll just show the diagram first. Now, so that's the sternum there in the midline. Then you have the PEX major here. Then you have the intercostal muscles there. Okay, so for a pectointercostal facial plane block, so that's the name suggests. Okay, pectointercostal is between the pectoralis major and the intercostal muscles. It tends to block the anterior cutaneous branch of the intercostal nerve, which supplies the midline. So basically, it can be used for sternotomies before cardiac surgery or in any surgeries involving the midline of the chest. So that's one blockade where it's given between these two muscles. If you go one level further down, you can give what is called the transverse psoriasis muscle plane block. Here you go below the intercostal muscles or between the second and the third intercostal muscles. So we have the external intercostal, internal intercostal, and the transverse psoriasis muscle. So this block is similar to the tab block in the abdomen. So it's a counterpart of the tab block in the abdomen. It again blocks the same nerve and can be used for the sternal procedures. But having said that, the risk of dural puncture is higher with the, pleural puncture is higher with the transverse psoriasis muscle plane block. So the pectointercostal block would be sufficient and safe. Yeah, so that's why I deficit them. And for the transthoracic plain block with deficit anesthetic in this layer between the second and the third intercostal. Greater auricular nerve block, it's part of the cervical plexus and it can be given for mastoid surgeries. So that's why you inject it. So posterior part of the sternocleidomastoid at the level of the thyroid cartilage. The R1 nerve block is used for merringotomies, which is again very commonly done in children, for wax clearance and merringotomy. So it's basically a branch from the vagus. So this is where you inject the drug at the tragus of the ear and you have fairly good pain relief. Maxillary nerve block, again, it's not something which is commonly done. I don't have much experience with this block. It's done for cleft palate surgeries or any surgery which involves this particular dermatomal level. The maxillary nerve is from the trigeminal nerve, the second branch. Okay, so it's best done by ultrasound. So what you do is you place the probe in the infrazygomatic region, and the needle entry is in the suprazygomatic place, where the orbital bone and the zygoma meet. That's where the needle should enter. And you will see two sort of bony structures there, and the fossa between them is called the pterygopalatine fossa, and that's where you inject the drug. So in summary, renal anesthesia should be an important, should be a mandatory component of perioperative analgesia, because one is it minimizes the dose of opioids you use, and you have a very comfortable child at the end of the anesthetic. There are significant differences between adult and a small child, and between a small child and a neonate, and be aware of what it can do. And this can also increase the risk of toxicity in a small child. When you have a preterm coming for any form of surgery within the first 50 weeks of post-conceptual age, think of spinals as the only option. And if you're not trained in ultrasound, I think time to get trained in them. And the more you do, the better. And finally, there is a trend and transition from central blocks to peripheral nerve blocks, because the safety is better and the efficacy is still the same. So that's a child after a circumcision. So rewarding to see a child so comfortable. This child in the recovery after circumcision, after a caudal block, I think. So child is happy and sleeping. So if you can have this kind of a child in the recovery, then you've done your job. So you don't need to worry about anything. So thanks for listening, and we're open for any discussion, queries, comments, whatever. So yeah.
Thank you, sir. Thank you very much for an informative talk. Now over to moderators. Gurudat sir, Balbhaskar sir.
Thank you very much, Dr. Sanjay. It was an excellent talk, and I really appreciated the way you explained the tips and tricks of the pediatric regional anesthesia. So, probably maybe about 10-15 years back, only a few of the blocks that were given was a caudal block or a penile block or an axillary block. Now it is said that, with an introduction of ultrasound, so any block that has been, that's being practiced in adult patients can be practiced in pediatrics also.
Absolutely.
So that's how, regional anesthesia in pediatrics has come up a long way now, for maybe about 10-15, since about 5-10 years probably. So one of the things I just wanted to ask you is, we all know that the local anesthetic toxicity is additive. That means if I'm using two different local anesthetics, so actually I'm not supposed to use the maximum dose of each. That is what every book tells, but practically we are not doing that. We are using the maximum dose of both, even in adults also, in pediatrics also. But we are not finding any patient developing any kind of toxicity. So what do you think about it? Though it's actually incorrect to practice the maximum dose of two of the local anesthetics, because the additive effect is also there.
Yes, I mean, I think, yeah.
I don't know what you also must have practiced.
Yeah, it's interesting that the human body is so resilient. though we do so many things which are wrong, still we don't land up in adverse effects. But I think the other way to look at it is, even if you have one adverse effect which sort of kills a child, that can be an event which can ruin you for life. So why take a risk? So and legally you cannot defend. And a lot of people have this practice of giving more but documenting less. But even one complication, I think it's something which I will feel guilty if I do that and if I have this problem. So.
Yeah, correct. Because, a lot of postgraduates are also listening to our, discussion. It is very important that we should not use the maximum dose of each one, because local anesthetic systemic toxicity definitely is additive when we are using two local anesthetics. That's one thing. Second thing I just want to ask you is, many of the books always give use of adrenaline along with either bupivacaine or whatever the local anesthetic we are using for caudal analgesia. So the thing that it is said that it is not for decreasing the or increasing the total dose or prolonging the duration of analgesia. It's mainly to decrease the toxicity, because once you use adrenaline, the amount of absorption of the drug will get delayed. That is why I have seen many of the books using adrenaline along with bupivacaine for caudal block. So I think because in one of the slides you said that there is no point in going and use adrenaline along with the local anesthetics. So
yes, I mean your point is well taken, sir. So you're saying by giving adrenaline, you minimize the absorption of leukocytes from the site of injection. Yeah, for that reason you can give it, but for detecting intravascular injection, I think they're saying it's not the best one. So you could still be in intravascular and you may not have a warning sign when you use adrenaline. So
yeah, another advantage with adrenaline, it's alpha-2 agonistic activity also could produce added analgesia.
Okay.
So when we use adrenaline. So in our days, I think maybe about 15-20 years back, we used to practice what was called as a double caudal.
Okay.
So what we used to do is we used to use a 22 gauge cannula. Mm-hmm. So we used to place the cannula into the caudal epidural space. So inject the local anesthetic for the intraoperative period, analgesia. So leave the cannula there. So after the surgery is over, because especially for prolonged surgeries.
True.
So once the surgery is over, so we used to inject another dose and we used to take out the cannula. I don't know whether you have practiced any time this, because nowadays you can even place a catheter, of course, but during those days, so catheters were not practiced for caudal catheter, so we used to use this double caudal.
So since we use buprenorphine quite frequently, so we find that for the next 24 hours we don't require anything.
Yeah,
so.
That's there. And one more thing is the needle that has to be used for caudal epidural, because it is said that we have to use a stiletted blunt tipped.
True, very true, sir, very true.
And a short bevel needle.
Though that is recommended, sir, to prevent the risk of implantation dermoid. The availability of spinal needles in very small children, it seems to be a problem. So I think across the world, I think a lot of people still use hypodermic needles, though it's not the ideal one to use. The stiletted needle is always the ideal one.
Yeah. So do you practice, pushing the catheter almost to the thoracic region? Suppose if the analgesia for some thoracic surgery is required through the caudal route in infants?
No, sir. We try not to do from the caudal route, though it is recommended.
Yeah.
The main thing we're worried about is infection from the pamper and from the diaper and things. So we rather go for a higher level like lumbar or the sort of low thoracic. Though you can do it if you're not confident of doing a thoracic or a lumbar epidural in a very small child because of risk of dural puncture or cord injury, you can go from the caudal route.
No, because
people who do this rarely can go for the caudal route because the risk of injury is less. Whereas thoracic, you have to be very careful. Yesterday, I did a caudal for a 4-month-old child for Kasai. I got the space in half centimeter. So you have to be so precise, otherwise you could sort of go straight into the cord.
No, because I know one pediatric anesthesiologist who regularly practices pushing the catheter to the thoracic level, especially for surgeries where thoracic surgeries are required. Especially tracheoesophageal fistula, repeatedly used to do this for many of the children. And he used to say that used to get very good analgesia for the child, even in the postoperative period.
Okay.
So there are some questions also on the chart box. So one of the questions is, for sternotomy, resuturing, do you give Pectointercostal bilateral?
Yes, it has to be given bilateral because it's coming from both the sides. Yeah, it has to be a bilateral block. So you have to give a dilute concentration and stay within the toxic dose. Yeah.
Another one
do you
is
use intranasal nalbuphine? No,
yeah.
I've never used nalbuphine. In fact, last week we had I gave a talk about pain management in pediatrics. One question was the same question. So no, I've never used nalbuphine. So anyone else who has used in the senior faculty, feel free to volunteer, sir. Anyone else has used nalbuphine in this forum? I haven't used. Though it's one is it's easily available, they say. Second is it's a partial agonist antagonist. So they say the risk of respiratory depression is less, but personally I don't have experience using it.
And then, what else can you use then instead of adrenaline for intravascular detection?
So as I said, there is no sort of agent which can clearly indicate intravascular injection. So that is why they recommend that you stay within the toxic dose. That is one. They regularly watch the ECG. Two. Third is give slow injections and give injections incrementally every 1 or 2 mL. Keep watching the monitor and give it slowly. So these are safety precautions. But no, there is no specific drug which can 100% detect intravascular.
As you shown, one of the ECGs you were showing, any intravascularly, if the local anesthetic goes, the tall T waves immediately will appear. That is one of the signs of intravascular placement of the drug. So that was one of the things. And the other thing is, you said other adjuvants are available.
Yeah, so the commonly used is clonidine, dexmedetomidine, buprenorphine. Some people use morphine in the dose of 20 to 40 mics per kilogram. But again, morphine, there's a risk of sedation, there's late respiratory depression. So if you're giving morphine, you have to monitor them in the HTU or ICU with a monitor. And some people also use ketamine, but ketamine, the one they recommend abroad is called S-ketamine. The one which we have is racemic ketamine. So S-ketamine has less incidence of this neurotoxic effects. So that is recommended. But since in our country we don't have that, I personally don't use ketamine. Some people also use dexamethasone as adjuvant in various blocks. Dexamethasone, dexmedetomidine and dexamethasone both can be used. Dexamethasone, the evidence is less. Dexmed, the evidence is good actually. So, but yeah, personally I stick to dexmedetomidine, clonidine. And ketamine can be used in the peripheral nerve blocks, but not in the central nerve blocks. You're excellent.
So another thing is regarding identification of the lumbar epidural or caudal, thoracic epidural space. I think better to go for saline rather than air. I think in this pediatric age group.
Yes, I go for saline. I don't use that.
Now, because ligamentum flavum is very thin. One. Second thing is we don't know intracardiac shunts there may be there. So even a small, even 1 ml of air can produce paradoxical embolism in these children. Yeah,
it can cause pneumocapsulis, and saline is not compressible, so you get a better feel when you use saline. So I go for saline. I don't use that.
Okay, Bhaskar.
So you're not audible, sir. So you're still muted, sir.
No, I think
okay. Someone has enabled him. Okay.
Yeah, now they are really.
Yes, sir.
They have blocked me. Right. Thank you. Thanks a lot. Such a nice presentation and succinct to the point, basically. And of course, in terms of the regular blocks, brachial plexus block in pediatric age group. So we do get a lot of patients in the younger age group due to some road traffic accidents and all. What would be your advice with respect to, for example, usual upper limb fractures in pediatric age group?
Yeah, no, I didn't cover because I think brachial plexus blockade is covered in every conference, in every workshop. And I think in terms of differences, I don't think there's many major differences. But obviously, I use ultrasound for all the brachial plexus blocks. And if a child has got a very short neck, I go for an infraclavicular block, which is almost as effective as a supraclavicular block. So infraclavicular block is better than because it's away from the major vessels and it's away from the pleura as well. So that is something. If those blocks don't work, then we can go for the peripheral nerve blocks. We can do individual block the axillary, the radial, radial nerve, medial nerve, and the ulnar nerve. All can be blocked at the forearm level.
Yeah. So those ones are supracondylar, usually fractures are the ones which they frequently come with.
Yeah. So for that one, infratarsal block should do good. So
that could work. Yeah. So one thing I was definitely happy was the small point about the tonsils.
Yes.
So I think, it's good. And of course, we follow in our institution, but I would be happy if it is more widely followed in different institutions also. So definitely at the beginning of the surgery, or normally at the beginning will be ideal, because analgesic requirement would come down. And it's such a simple block. So that's the one thing which will keep the child comfortable, and emergence would come down. Those reactions would be less in such patients. And of course, technically speaking, I think we should be talking about, of course, it's taken for granted, a Luer lock syringe with needle for an intraoral injection, or say that the needle is nicely secured at the hub. So these are some important precautions we should be taking, technically speaking, in those areas. The penile block, it is for circumcision. Of course, you spoke about hypospadiasis. So what would you suggest about the penile block, like the standard block, or something like a ring block?
Yes. So what my experience with penile block is, if someone is not, we have a failed caudal block or cannot do a caudal block for whatever reason, we do this penile block, the dorsal nerve block. But what happens is, in the dorsal nerve block, there is still some sparing of the ventral aspect of the penis. So we need to give a ring block as well, apart from the dorsal nerve block. So only ring block may not work. A dorsal nerve block with a ring block gives more complete anesthesia of the penis for circumcision.
Okay, so it's a common procedure generally which is performed. So it would be like initial sedation, come general anesthesia, followed by caudal analgesia, followed by dorsal nerve of penis block, plus some infiltration in the ventral side. So this would be the combination.
No, so sometimes when they have an obese patient, we think the caudal space cannot be accessed, or we have a patient who's 12 years who are having a circumcision, we go for a straight penile block. So we just hold a mask with the oxygen nitrous TiVo, get an IV, do the penile block, and let the surgeon do it. So it's not a rescue procedure. Sometimes we go straight for a penile block in this situation.
Okay. So one more thing I would just want you to explain to our PGs is with respect to how to appreciate the onset of spinal anesthesia in the pediatric age group. Like whether in the adults, we do talk about pinprick and bromide scale and other things.
Yeah.
What about the assessment in a neonate or an infant?
Yes, sir. So after a spinal, one is obviously there is motor blockage. That is one. Second is they will go floppy. Third is if you have a pulse oximeter, apart from the pulse oximetry reading, in the recent ones, you have something called a perfusion index. It comes as a small number, let's say 3.5, 4.5. So what happens is, if you do the pulse ox, if you put a pulse oximeter in the foot before the spinal and after the spinal, you will see a sudden increase in the perfusion index once the spine starts working. So basically, the perfusion index is basically an indication of the perfusion and vasodilatation. So that tends to increase after a spinal or a caudal. So that's a fairly good indication that the spinal is working. And obviously, response to any incision or something, they will not move.
No,
level of the block is very difficult to appreciate, I think.
Level of the block can be difficult. Yeah.
Unlike in adults, because adults will be awake. So definitely they can appreciate where we are, putting a pin or swab with spirit. So pediatric, it may be difficult. That is
floppy lower limb, yes, we can make out the motor blockade, and sensory blockade, as you say, is a little bit on the compromising side. And this is okay because we depend upon the paralysis. For caudal epidural, what would you tell our PGs with respect to the onset of the blockade, motor and sensory?
So generally what happens is with 0.5 milligrams per kg, which they recommend as per the Armitage formula for penile surgery, it takes, by average time, it takes us 10 to 11 minutes. So what we do is we have very surgeons who are very always in a hurry, actually. So what we do is we increase the dosage. We increase it to 1 ml per kg, and even with that one, it takes 6 to 7 minutes for the caudal to work. So that's something which we consistently observe. So basically, it's timing the caudal block to the noxious stimuli of when the surgeon starts. Otherwise, it's very difficult to sort of tell when the block tends to the onset of the block, or when the block is completely good enough for the surgeon to start. Because many times what happens is the surgeon starts without the caudal fully acting, and you're just holding a mask. The moment he puts force of something, they will go for laryngoscopy.
Yeah, one of the possible things we can assess for is the loss of anal tone. Reduction in the
yeah, that's something which they recommend, but though I don't know whether we do it practically.
Practically don't. It's we may not
do
it.
Anal tone is fine. Sphincter tone is fine. Yes, sir, that's correct.
We tend to offer, we tend to wait, and like you said, some amount of general anesthesia is always there. So assuming that the drug has acted, we lost a surgeon to go ahead. So that's the way it is.
Yeah, that's a nice point. So, yeah.
So in our institution, Dr. Sanjay,
yes,
so for hypospadiasis repair, they are not allowing us to put a caudal epidural. So it can produce, penile erection, so we may not be able to do a proper correction of the hypospadias. That's what their grouse. So that's the reason many times we put a caudal epidural after the surgery is over. So do you have any such problems in your institution there?
No, sir. So we have two surgeons operating. One doesn't want a caudal, one wants a caudal. So we get to do both. That's why I learned this pudendal nerve block, sir. I think it's something which all of you should learn, and to try. It's quite an easy one to do. You need to have an ultrasound though. The surgeon who doesn't want a caudal, the reason saying the caudal will cause increased blood flow to the penis, and he thinks there'll be increased bleeding when he does hypospadia. So that's why we went ahead with the pudendal nerve block. But the other surgeon is quite senior, but he's okay with the caudal. So sometimes it's difficult to sort of satisfy the surgeons. Each one has their own perspective. So sometimes we have to tailor our practice according to the surgeons. Being in the corporate sector, I think, we'll have to satisfy the surgeons as well.
What about your opinion for spinal anesthesia in older children? Because I never practice spinal anesthesia for older children, only for, as you said, that premature child.
Yeah, I mean, older children, as I said, if they cooperate, sir, we've done it for a few situations where they're coming for an orthopedic procedure in the lower limb. If a child can cooperate, then we offer a spinal. But even if we offer a spinal, we sedate them with propofol infusion just to keep them they're anxious as well. So either midazolam or propofol infusion.
Yeah, because I still,
but not frequently.
Correct. I still remember a child had given a spinal, about 12-year-old child. So he was so restless because he was thinking that he has lost both of his lower limbs.
Okay.
He was not appreciating because he was not getting the afferent impulses from the lower limbs. So I had to give him GA afterwards.
Oh, okay.
But many of the anesthesiologists in the rural areas, they do practice spinal anesthesia for pediatrics. Many of them. Rural areas where the anesthesiologist is taluka level hospitals. Extensively, they are practicing spinal anesthesia for pediatric age group, 2-year-old, 3-year-old.
So 2-year-old, 3-year-old also, okay.
Yeah.
Dr. Ravi, sir? Sir, go ahead, sir. Go ahead.
Yeah, good presentation, Sanjay Prabhu, wonderful presentation.
Thank you, sir.
I think Chennai Apollo is known for this medical hub. We've been doing a wonderful job. Myself, Dr. Ravi, Professor HOD here.
Okay.
I thank to Shivkumar, Manjunath, who've been doing a wonderful job. I think you've been exhausted with a lot of questions from the two moderators. Just I have two questions to ask you.
Sure,
I think it's not exhausting for you. Hope not exhausting for you. So what is it right? Yeah, after giving buprenorphine, you find any delayed respiratory depression, something like that? We have
no, sir. Actually, no, sir. So that's why we start off with 1 microgram per kg, then increase to 2 micrograms per kg. So so far we have not had any depression, sir. Okay. I think we've been practicing it for almost 4 years now. We give it for all caudal patients, all hypospadias patients having caudal. We add buprenorphine. But of late, last 2 months, there seems to be some problem with availability, so we've not been giving that. But up to now, we've never had issues. And most of the times, if we go and see them the next morning, they're still quite comfortable. Usually, the pain starts maybe the next afternoon or something.
Yeah, I know.
We've not had any issues, sir.
We had one patient about 6 years old. We gave something like epidural, the buprenorphine. That is Catheter and myself. Femoral till grafting, in fact.
How much dose was given, sir, per kg? Do we know?
Yeah, that patient developed exactly. I just have to look at it. It's a long back. So that patient went to depression when we were not there. Postgrad couldn't be able to identify. Actually, we lost that patient. In fact, it's a long back story when I was working with Catheter surgeon, Dr. Subrao. So these things do happen when sometimes when you give, thinking that I feel sometimes statistics is a very dangerous drug. When you give it epidurally, I found it myself as a complication there. Okay.
Okay, sir.
Then the next thing is for the information of the postgraduates. I have a question with you. Right, you take some time for this, like doing the process, say about 15-20 minutes to, at least, right? It happens to you, right? Yeah. How do you make this patient to sleep? Do you intubate and do you give some sort of sedations to sleep? What exactly you do? The postgraduates have been, they hold the mask sometime. They'll be in confusion whether to give some sort of ketamine or somebody intubate them. So I think what is your message, take home message before giving these procedures to stop the child, to make the child sleep? What do you do exactly?
Okay, it depends on the type of the procedure and the duration of the procedure. Sir. So the common procedure is circumcision. Sir. So what I do for circumcision is obviously induce the child either inhalation or intravenous, then do the caudal, and once the caudal is in, after that, it takes they'll take 20-25 minutes to finish the surgery. So during the time to keep the child sedated, I sort of give incremental doses of propofol, just 1 or 2 ml as and when required. Sir. That's all I do for circumcision. Okay. For surgeries where we think it's going to be longer, let's say 1 hour or so, I put an LMA, LMA and sedate them. But if it's surgeries, things like a laparotomy or a surgery where you think there's going to be blood loss, then those situations intubate, sir.
Oh, so you got a lot of options to do that, right? Yeah.
Yes, sir. Yes. Sir. So
many, right? Depending on the duration of the surgery.
Depending on the duration and the type of surgery, sir. Yeah.
But when you do this thing like ultrasound and guided, you take at least half an hour. So do you really intubate this patient? Say like you do some ultrasound guided nerve blocks, right?
Yes, sir. So, for example, if I'm doing a brachial plexus block for a child having some kind of a lesion in the radius, then we generally, because if it's close to the neck, generally we try to intubate them, sir. We intubate them and then do the block. Obviously, the child is fully anesthetized and then we do the block. So this block is mainly done for intraoperative and postoperative anesthesia.
You need to be done. You need to be done because you need an exact, silence of that area, silence of the child.
And we need an immobile child, sir. So, and the closer to the center or the closer to the airway they are, I think better to sort of sedate them completely and intubate them maybe. So.
Thank you, Sanjay Prabhu. Over to Shivkumar, sir. Shivkumar.
Thank you, sir. Thank you, Ravi, sir. Azam, sir, is here. Dr. Azam.
Thanks, Dr. Shivkumar. Thank you, Manjunath, sir, and Shivkumar, sir, for giving this opportunity. Sanjay, excellent presentation. Just to answer Balabhaskar sir's question on brachial plexus. If you don't mind, can I add a couple of points?
No, absolutely, Azam. Yeah, absolutely. Yeah.
Right. Just for Balabhaskar sir, he was asking about brachial plexus block. So, sir, one thing we need to keep in mind when we're doing a brachial plexus block, suppose we have a humerus fracture, but if there is an associated clavicle fracture, you got to be very careful in giving a brachial plexus because the sheath surrounding the brachial plexus, there might be a breakage and it can get into it and it acts like a central neuraxial block. So we have had at least 2 patients, one was adult and one was pediatric. So this is one thing I think we need to keep in mind. Other thing, I think Gurudat sir was asking about the epidurals that are passing through the caudal. if I'm not mistaken. I think Gurudat sir mentioned, why don't we pass a catheter through the epidural till thoracic? There was one excellent study by Manoj Karmakar sir. And what he did was he used stimulating catheters. And many times he found, even in spite of, he used combination of ultrasound with nerve stimulator and a nerve stimulating catheter, where he tried to push it in, and couple of cases where he found the catheter to go and get, king and come back again. So it's little difficult to do that, but it's definitely not possible. So these are my 2 points I thought. Thank you, sir.
Yeah. Thanks, sir. Well taken points. Yeah, very valid points.
Nice discussion. Sir, facial plane, cleft palate, do you give any analgesia techniques, greater palatine nerve blocks, anything?
No, I think that's done by the surgeon. I'm just starting to try this maxillary nerve block. I wouldn't say I've done much. So maybe for 2-3 years from now, I might have a better picture.
In fact, Shikumar sir, we were giving that infraorbital.
Yes.
What we found was, after giving the block, the child used to cry a lot, because they used to feel some sort of a numbness. So when just the internal audit when we did, then when we did a group of babies without a block, then they were much better off than the babies that were given block. So we have totally stopped giving that actually.
Okay. Thank you, sir. No. So any more questions from the chat box? Any questions are there? Right. Sir, thank you, sir. It's a wonderful, informative lecture by you. Thank you very much. It's a nice discussion from all the moderators. Thank you very much. Thank you all the moderators and delegates and ISAKA Karnataka office bearers. Thank you very much for. Thank you very much, sir.
Thanks for having me.
Thank you, sir. Thank you,
sir.
Thanks, Ajay. Good night.
Thank you, sir. Thank you, sir.
Yes,
Good night,
sir.
sir.
Thank you.